Hello everyone, my name is James, and today I'd like to present to you the research I've been working on with this term in this internship. The title of our presentation is Efficacy of Transition from HBIG to an all-oral nucleoside regimen after liver transplant for Hep B-related disease. So, just a bit of background, but in general, when talking about hepatitis B, it's important to talk about three indicators of viremia: presence of surface antigen, indicative of a chronic infection; presence of envelope antigen, indicative of replication; and the viral load. And these will come up later in the presentation. But in general, it's clear that hepatitis B presents itself as a very enormous global burden on our health systems, with 2 billion current and past infections. And with many people undergoing transplantation as a result of cirrhosis and hepatocellular carcinoma, it's clear that hepatitis B poses itself as a significant problem. So, after transplantation, the goal is to prevent the allograft, or the new liver, to prevent to undergo reinfection. However, back then in the 1980s, this was easier said than done, with 80% to 100% of all recipients undergoing reinfection after transplant. This led to many transplant centers abandoning transplantation as a viable option for Hep B patients. It wasn't until the advent of hepatitis B immunoglobulin, or HBIG, that liver transplantation became a viable option for chronic Hep B patients. And with the advent of nucleoside reverse transcriptase inhibitors, or NRTIs, the outcomes of patients undergoing transplantation became hugely improved. Although lamivudine and the rest of these NRTIs are not used nowadays, tenofovir, entecavir, and Truvada are currently used here at CPMC and many transplant centers across the U.S. They have shown themselves to be efficacious with no to minimal resistance to hepatitis B. So, HBIG is used as the backbone in combination with these NRTIs as prophylaxis post-transplant to prevent reoccurrence. Response to HBIG, however, is dose-dependent, and prophylaxis protocols vary across the U.S. But here at CPMC, we do have our own protocol. So, I just want to bring up a bit of past protocol. So, back then, both high-risk and low-risk patients, you can see that we use significant amounts of HBIG. So 30 mils is a very high dose. We also use the older antivirals from back then. But what I want to emphasize here is that patients undergoing transplantation were to receive HBIG indefinitely until the new protocol, June 2011, which not only dosages were decreased from 30 to 5 mils, not only did we start using the new antivirals, tenofovir, entecavir, and Truvada, and so on, but what I also want to emphasize here is that patients undergoing liver transplantation are only to receive HBIG for 6 months, and then subsequently discontinue it and to go on antivirals for the rest of their lives, 2 antivirals. So why am I bringing the past protocol? It's because HBIG itself has many advantages, but also has many disadvantages. It is efficacious in preventing recurrence. However, HBIG is very expensive, as you can see here. It also poses itself as inconvenient, and long-term dosages and duration have been said to be uncertain. So this leads us to our hypothesis that shorter duration, lower dose HBIG, combined with dual oral antivirals, will be just as effective, if not more effective, in preventing HBV recurrence. The aim of our project was to evaluate the efficacy of this transition when putting our patients off HBIG and subsequently putting them only on antivirals. Oral antivirals. So what did we do? We evaluated patients who underwent liver transplantation at CPMC between 1991 and 2015. We extracted the data from Otter, and come June 2011, we transitioned all patients, old and new, to this new protocol. And we followed them up from then. So just a bit about our study timeline. So first we started with 106 patients, and after 20 failures to transition, we ended up with 78 patients. From then on, we split them to 3 categories. Subset 1, which consisted of patients who were transplanted before June 2011, and were subsequently switched to the new protocol on the data. We also had subset 2 criteria, which consisted of patients who received their transplants before 2011, but were transitioned way before due to various reasons, such as lack of insurance coverage. and subset 3, which consisted of patients who were transplanted on or after June 2011. And just a bit about the patients who were in transition. We had 5 patients who were high risk, therefore we were unable to transition them to the new protocol. 2 patients experienced virological breakthrough, 2 patients had resistant virus, and so on. The rest of the patients could not transition due to miscellaneous reasons. And what did we do after? We followed up their labs at the time of transition, followed up their surface antigen levels, surface antibody titers, envelope antigen, and so on. And we followed their labs up to July 15th, 2016, the last day of our study. So what we looked out for at this time was whether any patients did seroconvert, did show recurrence of HBV. And we defined that as exhibiting reactive surface antigen or a viral load of above 20 IUs. And some characteristics, with a mean age of 58.4, most of our patients, as expected of Hep B, were males of Asian descent. Most patients underwent liver transplantation as a result of hepatocellular carcinoma and cirrhosis. All patients were positive for surface antibody at the time of transition and were negative for surface antigen at the time of transition. And results. So after the transition, we had to discontinue the transition for 7 patients for various reasons. Some patients were intolerant of the new medication, some patients became high risk, and so on. But eventually, subset 1 ended up with 25 patients with a mean follow-up of 48 months. Subset 2 patients had a mean follow-up of 79 months, and subset 3 patients had a mean follow-up of 27 months. And in total, we had a total of 71 patients who made the transition from HBIG to dual antivirals. Out of the 71, 65 maintained inactive status without a reoccurrence of hepatitis B, with a mean follow-up of 42 months. However, we did have 6 patients who did seroconvert with a mean follow-up of 55 months. So with these patients who did seroconvert, all of them did exhibit reactivity with surface antigen. However, only 2 patients showed detectable levels of DNA in their system, and only 1 patient showed detectable elevated levels of aminotransferase. However, I'd like to say that 3 of the patients, including the patients who were detectable for DNA, were non-compliant with their medications, which played a big role in the reason why they seroconverted. But in discussion, we could see that this transition from HBIG to all oral nucleosides has been highly effective, with 92% efficacy, and while there were a few seroconversions, 50% of them were due to the suboptimal compliance with medication. Also, previous studies have been done on this. For example, at New York University Medical Center, a study done by Louis Tepperman showed after withdrawing patients from HBIG to Truvada only, there was a recurrence rate of 0%. However, they did have fewer patients, and they had a shorter follow-up of 72 weeks, as opposed to our 42 months. So, with the strengths of our study, we can see that with a large number of patients, this is the largest to date literature report on this subject. In addition, with a single protocol, patients were able to follow the new protocol with a high adherence rate. Finally, with a large and near complete data set, this research has very important cost implications for the future, with HBIG alone costing $10,000 to $100,000 a year, depending on transplant center, in addition to oral nucleosides. A discontinuation of HBIG would be highly cost-effective for patients and would lighten the financial burden on them, not to mention the cost of transportation and invasiveness on patient lifestyle. However, our study does have some limitations, with it being retrospective, be done only at this center, the fact that we have to exclude all high-risk patients, the fact that a significant portion of our patients did not transition, and we are missing some recent data which we're trying to fill in the holes for. But in conclusion, we can see that a transition from HBIG to an all-oral nucleoside regimen after orthotopic liver transplantation for HBV-related disease is highly effective. So I just want to thank Dr. Merriman for overseeing me and mentoring me throughout this whole project. I want to thank the transplant department for making this internship possible, and I also like to thank Linda Lee Megan Grange, and Book Dow for helping me with the logistics of this project. Thank you.
Good job.
Well done, James.
Yeah.
Good job.
Next presentation.
Who is Ms. Joseph?
Next presentation. Yeah. Thank you, guys.
Thank you.
Yeah, good job.
Hold on, it's not her. This is-
Application was fine. Nothing like the administrator.
that's it, congratulations.
Good.